Greetings, everybody. Today we're talking about acute bowel obstruction and just some issues that we might encounter in the ED, particularly questions relating to things we might be doing. So I have a case for you. A 58-year-old man presents with severe abdominal pain after 2 days of fever and loose bowel motion. On examination, he has a distended and tense abdomen. We make a diagnosis of acute bowel obstruction. His vitals are as follows: pulse of 127, resp of 40, and a blood pressure of 102 on 84. So as you can see, he is quite unwell. So we initiate management, which includes sepsis management, fluid resuscitation, antibiotics. Surgeons are informed, IDC inserted, and we start documenting fluid balance. So as we do this kind of management, we might ask ourselves a few questions, and I want to take us through these. So the first question we can ask is, out of everything we're doing, which one is the most important management? Is it the fluids, antibiotics, pain, or surgery? Now, the correct answer is actually all of them are important, but I want to point out the special role that surgery plays. Fluids, antibiotics, and pain relief are all part of the management, but surgery is the thing that actually will cure the patient, so to speak. It will treat the underlying cause, and this is really important for reversing the whole pathology. We have to treat the underlying cause. So in the emergency department, what I want to highlight here is it's great we go ahead and start the fluids, put them on antibiotics, relieve the pain, but it's also really, really important that we get the surgeons to come and review the patient. And this is a matter of priority. We have to get on the phone, get the surgeons, and make sure they come on time and make sure that's not delayed. This is really important for a best possible outcome for this patient. Let's move on now and talk a bit about fluid balance. So fluid is something we very commonly use in the emergency department. And why is it important? Well, tracking the kind of fluids we give patients is important for 3 reasons I want to point out. 1, it tells us how much fluid we're giving. So if we're resuscitating enough or not, we will know by looking at the volumes we give as well as together with our clinical assessment. We can also use fluid balance to detect any acute renal failure early, and we also track it to make sure we don't give our patients too much fluid because it can cause harm later. Doing a fluid balance is fairly simple. It's just a matter of measuring and recording how much we put into the patient, so IV fluids, oral intake, and so forth, and how much the patient puts out, so any blood loss, any vomiting, and of course urine output. Now I want to talk about urine output here. So how do we measure urine output? So sometimes I see this not being done in quite the way I think it should be. So if you're going to measure urine output in the emergency department, particularly for patients like this patient we're talking about, who is critically unwell, we want to measure urine output hourly as a measure of how well he's doing. So the first thing, of course, is to insert the IDC and drain the bladder completely. Once the bladder is drained, empty the bag, and it's important now to document the time of this emptying of the bag. This is the 0 starting time by which we'll measure urine output. And then every hour, you will measure the bag, often by emptying, and record this number in our fluid balance chart. There's different kinds of bags we can use. So sometimes you can get bags like this, urine bags like this, that actually have a measuring chamber built into it that allows you to measure small volumes. So if you have such bags, those are really useful to use. But these kinds of bags are possibly more common in the Pacific, and we cannot measure small volumes with these, so you actually have to empty the bag into a measuring device in order to get accurate amounts. If we're measuring urine output, it'll look something like this on the chart. You'll have times on one side and amounts on the recorded on the other. Now notice the volumes are written there, 42 mils, 35, and so forth. These are usually small volumes that we'll be seeing in these patients. So having a measuring cylinder like the one I have on the right side of your screen is very useful in being able to measure such small volumes. You cannot measure it directly from a bag if it's like the second bag I showed you. Let's ask another question. How much urine does an adult produce every hour? So if we're measuring the urine, then we should also be concerned about how much they are making every hour. Is it like 10 mils, 20 mils, 50, 100, or more than 100? Well, let me give you a figure that you can use. So if you're measuring urine output, particularly for nurses, and you find that the patient is producing less than 50 mils per hour, this is a signal that you should inform your doctor. So adult patients should produce about 1 ml per kilo per hour of urine. So for a 50 kilogram person, you expect around 50 mils. If they're producing less, this could be a sign of either inadequate resuscitation or patient going to renal failure. If they produce more, that's also abnormal. So producing more than 100 mils per hour, that can be also abnormal. But in patients with acute bowel obstruction, the issue is often that actually they'll be producing less. So if you have bowel obstruction and you're having a patient producing less than 50 mils per hour, nurses, let your doctor know. And particularly for doctors, if the patient is producing less than 25 mils per hour, you should be considering the presence of acute renal failure or significant under-resuscitation and considering taking steps to treat that. Now, it is not uncommon to find nasogastric tubes inserted for bowel obstruction patients. But one can ask, should we be inserting NGTs on every bowel obstruction patient? Yes, no, maybe? So this actually has been looked at. Even though research into it hasn't been that extensive, people have looked at it and tried to answer this question. And the consensus is generally that not every patient will benefit from having an NGT inserted. This is with bowel obstruction. Some will and some won't. So the bottom line here is that not all bowel obstruction patients require an NGT. It has to be a case-by-case evaluation. Patients who benefit most from NGTs are ones who have collection of gas or fluid accumulating in the stomach. So that's a pretty high obstruction. If you have it lower down and the collection of gases and fluid in the bowel obstruction is much lower, say in the distal small intestine, then your NGT is not actually going to do any good. As a guide, patients who are persistently vomiting from bowel obstruction, they may benefit from an NGT, or patients with distended stomachs may benefit from an NGT. Doctors see the patient and make a decision, but you don't put an NGT on every patient just because they have a bowel obstruction. Now, acute bowel obstruction is a painful condition, and pain relief is an important part of this management. However, sometimes clinicians might be concerned that, if I give the pain relief and it changes the behavior of the pain, is that going to actually make a diagnosis difficult? This is an important question because if we delay giving pain relief, we're allowing the patient to suffer more, but at the same time, we don't want to mess up the diagnostic accuracy. So again, this was looked at, and this here is a study, it's a meta-analysis, so it looked at several studies, and these findings have been consistent with other literature that it is safe to give morphine early, and it will not affect important diagnostic decision making. If the patient is in pain, give them pain relief early. It will not affect diagnosis. So if we're giving pain relief, then another question we might ask is, how much should we be giving for the pain? Should we be giving 1 milligram to this patient or 2.5, 5, 10? And the appropriate answer here is that you should be giving as much as is needed, but we should be doing this safely, of course. So clinicians often worry about if I give too much morphine, is it going to stop the patient from breathing, or is it going to drop their blood pressure? And those are valid concerns because morphine does have side effects. We also have an important role to relieve suffering of our patients. So when patients are in pain, they're less likely to experience these harmful side effects of morphine if the morphine is used safely. Some patients might require less, some might require more, but the way we should be thinking is I need to be giving as much morphine as is required to relieve my patient's pain. So it's not by the number, it's by how the patient responds. So a safe way to do it, and this is the way I would do it, I will give, say, 2.5 milligrams to the patients initially, IV push, give them 5 minutes, and check them again. Do you need some more? Are you still in severe pain? If the answer is yes, I give another 2.5 milligrams. Wait 5 minutes and again reassess them. And I'll give as much as is needed until they are comfortable. Some patients, 2.5 is enough. Another patient, I might have to go to 10 milligrams. So it really depends how much they need. And that's how we should be thinking. Don't go by the number. Go by how much the patient needs in order to feel comfortable. But do this in a titrated manner so you don't want to give unnecessarily large amounts. So bottom line, give more morphine if the patient is still in pain. Now, investigations form an important part of our diagnostic process in acute bowel obstruction. And we have several imaging methods available to us, X-ray, ultrasound, and CT scan. So which one is actually better? This is more for doctors. Which is better for us to use to diagnose acute bowel obstruction? X-ray, ultrasound, or CT? And the literature gives us some numbers around the sensitivity and specificity of these modalities for acute bowel obstruction. And CT and ultrasound are way up there in the high 90s. And these give excellent sensitivity and specificity for making the diagnosis. CT in particular is good at identifying the specific cause of the bowel obstruction, informing any surgical intervention. Does it mean X-ray is bad? Well, actually, no. X-ray is still commonly used and has some advantages over ultrasound in specific situations. So if you think about abdominal ultrasound versus X-ray, which is what we currently have available in our set, my take on it is that they're both useful, but one might have an advantage over another in certain situations. So in my opinion, X-ray may be more useful in a distended abdomen if it's quite distended with gas to confirm the diagnosis. And this is because large amounts of gas in the bowel actually interfere with accurate ultrasound interpretation. But if you have an abdomen that is not that distended and without too much gas in it, such as in early bowel obstruction, ultrasound is going to be much better because it'll give you clear indication as to whether bowel obstruction is present or not. That's how I'd recommend it be used. X-ray, definitely for the very distended abdomen, lots of gas. And ultrasound, most useful in early diagnosis of acute bowel obstruction. So in summary, these are the take-home points from this talk, just to remind us of a few important things in the day-to-day work dealing with these kinds of patients. Number one, surgical review and management is a priority in our care, not to be forgotten. We should go ahead and do our emergency management in the ED, but getting the surgeons to come and see the patient is also very important and not to be sort of left till later. Regarding urine output, monitoring urine output hourly is part of monitoring these kinds of patients. So particularly for nursing, if you find urine output is less than 50 mils per hour, inform your doctor. This is something they need to look into. And for docs, if you're finding urine output less than 25 mils per hour, consider acute renal failure. And you may have to take steps to manage that. Now remember, not all bowel obstruction require an NGT. Evaluate your patient and ask yourself, will they benefit from an NGT? Regarding morphine, remember we can give pain relief early. It will not interfere with the diagnosis. Relieve the suffering of your patient. And lastly, ultrasound and X-ray are both important for investigation, with X-ray possibly having some advantage over ultrasound in the advanced or late presenting bowel obstruction patient. Thank you. If you have any questions about any of this, you can reach me on this email, and I'll be more than happy to help you. Alright, Olketa. Look him.